Good afternoon, and welcome to HealthSystemCIO.com All-Star Panel, Demystifying FHIR, a webinar tweet chat combo from HealthSystemCIO.com, sponsored by Infor Healthcare. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of HealthSystemCIO.com, and I will be your moderator today. We are having a simultaneous tweet chat hosted by Kate Campbell, our Managing Editor and Director of Social Media. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or if you just want to view the tweet chat, you can do that in the Media Viewer panel on the right-hand side of your screen. Other WebEx panels that will come into play today are the polling panel, which will open when we launch a poll, and the Q&A panel, which you can use to submit your questions at any time. Type them into the panel, leave the default set to all panelists. And you can download the deck using the URL on your screen, or it will also be sent out in the chat box during the event. Just so you see how we're going to spend our time today, we're going to go about 35 minutes with our panel discussion, and then we're going to have our audience Q&A. Overall, we're going to go about 45 to 50 minutes. On our panel, we have Dr. Shafiq Rob, VP and CIO at Hackensack Meridian Health Network, Dr. Daniel Nigrin, SVP of IS and CIO at Boston Children's Hospital, and Corey Spears, Director of Healthcare Interoperability Standards with Infor. So, without further delay, we are going to get started. Let's start with you, Dr. Rob. Can you give us a brief overview of Hackensack Meridian Health Network?
Thank you, Anthony. Hackensack Meridian Health Network is a network of about 12 hospitals and is a $5 billion in money and about 3,500 physicians, over 28,000 employees and staff, and we are continuing to support our friends and our families and our communities in the northern New Jersey up to southern New Jersey. And our continuum of care also includes other things like gym, healthcare, other healthcare facilities like rehabs, nursing homes, and also for to live healthy, we have other wellness programs that are associated with it.
Very good. Dan?
Thanks, Anthony. Hello, everyone. Boston Children's Hospital is a 400-bed academic teaching facility in Boston, Massachusetts. We're the primary pediatric teaching hospital for Harvard Medical School. In addition to clinical care that we do, we're a very big research organization. And with respect to today's talk, it's probably worth pointing out that we've got a very prominent medical informatics research component as well, and have been at the forefront of thinking about applications that can use infrastructures like FHIR, and I'm sure we'll talk about that more.
Very good. Corey?
Thank you, Anthony, and hello, everyone. So Infor is the third largest private tech company with nearly $3 billion in revenue. We have 14,000 employees, 9,000 of which are engineers. So in short, we do technology. We have products in many different industries. In healthcare, we're most well known for our flagship product, Cloverleaf Integration Suite, which enables data flow, routing, translation, and transformation of data between different healthcare IT systems. For that product, we have about a third of the market. But we also have a high market share in a number of other healthcare applications, including ERP, finance, supply chain, and human resources.
Very good. Thank you. All right, Dan, let's start with you on this one. I'd like to set the table by talking about the problem. And so let's talk about how things are if people are not using FHIR or were working pre-FHIR. We're going to identify the problem.
Yeah, I think it's a simple one, which is basically how do we extract data from an underlying EHR system in a standardized way? How do we move that data from one system to another? How do we avoid having to re-implement software solutions each time we want to think about porting them to a different underlying EHR. I think where we are now is that there's really no standardization. I mean, we obviously have things like HL7 standards that we've all been using to establish interfaces, and Corey's company obviously is always been there to help us in that task. But it seems as though it's always more difficult than it needs to be. And in many instances, you are always reinventing the wheel when you need to either extract this data or move it back and forth between various systems. So I think that's what FHIR really helps with. It standardizes a lot of these kinds of tasks. It simplifies them. And it sort of modernizes them, if you will. It uses 21st century application standards and data exchange approaches that we're now much more used to dealing with in a very web-centric world.
Corey, you want to touch on that idea?
Yeah, sure. So I think the goals and opportunities are shifting a lot. We're moving away from just a pay-for-procedure to more collaborative models of care. And this is increasing the need for new methodologies and interoperability. So as a review of where we are today, we can take a look at a few samples of standards in use. We have HL7 version 2, which has had a wild success. It's used all over the place. But it was designed in an era where the need was for communication between systems within a hospital system or within a practice. So that doesn't translate well to going beyond that. We also have the clinical document architecture and its partner, the consolidated CDA. And it's filled a gap in document sharing, and it primarily assists with transfers of care. And it has its own failings in that it's quite complex, and that creates sort of some quality issues in the wild natural use. And it was mostly designed to provide a snapshot in time. And these standards do address certain needs, but they don't well address needs for greater collaboration in the healthcare ecosystem, nor the ability to bring on new actors into the mix and addressing the expanding use case.
All right, very good. Corey, next time you speak, if you could just speak a little bit louder. We had a request from the audience, but thank you for that answer. Shafiq, do you want to talk a little bit about the problem?
Well, my learned colleagues have said it very elaborately, but what I can say is the following. The federal government wanted to change, as I call it, care transformation. It began with digitalization of the record. Second thing that happened is that make sure that the discrete data is available in machine-readable format. And the third thing was that to support it, they started changing the payment system towards value. All three things are happening. What did not happen during the implementation, that the gap that remains is interoperability. That means the information from one type of machine-readable format or electronic health record or digital format to go to the next one and to be available at the point of care or with the patient. So in short, what it means is that when you really need your information, and God forbid it is not in the same health system, it becomes very hard to get to it, to have actionable result, which results with everybody said, payment, money, healthcare, affordability, and most of all, the real care for the patient, and for the patient himself to follow over the course of time to decrease the cost of healthcare. And also, last thing is to decrease the waste in healthcare that we do. So all this is tied to a standard or a way, and in layman term, if you want to say, what is the problem? Problem is if I sit in my car and I want to listen to music or respond to my phone, I can't if my car doesn't have it built in, but if I have Bluetooth, I can. So for healthcare, FHIR becomes the Bluetooth of interoperability that allows from disparate people to talk to each other so you can enjoy your music or make your healthcare better.
All right, very good. Corey, I'm going to go to you on this one. Let's give people a little class on the origins of FHIR, who's sort of shepherding it, and I assume that is important to having confidence in this, the fact that someone is shepherding it, some entity that is known and respected, and people can have faith that it's not going to sort of go away.
Sure, absolutely. Well, it was born from a need to support newer interaction patterns, to utilize newer technologies that are being used across most other industries, and to enable internet-based interactions, and including enabling interoperability with mobile devices. Some of the needs that were being addressed in its creation were to create a lighter weight and simpler specification. It has a rule of thumb where what gets included has to be supported by 80% of the systems in order to include it into the specification, whereas some past efforts have tried to model out pretty much the universe. It's based on web standards, has a good support for use, including implementation libraries, examples, and open source reference implementations, and it is also a smarter approach to standards development. The standards and implementation guide development process actually create basic validation capabilities automatically. FHIR is created by HL7. HL7 is an ANSI-accredited standards development organization and is the foremost developer in healthcare IT interoperability standards, and it's been around since 1987. It follows an ANSI-approved consensus-driven validating process. As far as who is supporting it and and confidence in its development, I think, yes, it is important to know who's doing it. You want to make sure that the standards you use will continue to grow and are maintained, or they'll have a short lifespan. And HL7, it will be behind it and maintaining it. It follows a fairly rigorous process in its development. It's an open standard. HL7 has made it free for use, and it's vendor neutral. And there are a lot of stakeholders involved engaged in its development.
Very good. All right, we're going to do a quick audience poll. So you should see that poll to your right. Is your health system currently working with FHIR in any capacity right now, yes or no? If you are not at a health system, we're not trying to be super scientific here, just get a vibe. So if you have clients that are health systems, think about maybe your main client, or in general, the majority of your clients. We're just trying to get a feeling for how many folks out there are actively working with FHIR in any capacity right now. So go ahead, take a moment. Don't worry about, if you're not at a health system, again, just your best vibe of what's going on out there. Okay? Now, we've got a number of questions on this slide. So I'm going to read off the questions and then ask our panelists to comment wherever they feel most comfortable. Conceptually speaking, what does FHIR promise? What can FHIR deliver today? What are its limitations? And do you expect those to be overcome? When and how? And also, I want to throw in here, if you would like to talk about what your organization is specifically doing with FHIR, please go ahead and do that. So Daniel, let's start with you.
Sure. So as I started to allude a little bit earlier, conceptually speaking, what I think is fascinating about FHIR and really exciting is that it proposes to really standardize the ways that data can be extracted from and entered into an underlying EHR. And to me, that's one of the most important premises. And so what we're seeing is as the major EHR vendors start to implement FHIR in their products, they're initially starting with what I would offer is the simpler use case, and that's to read data. And I'm going to jump to the limitation point as well. I think for most of the implementations I've seen so far, there's fewer abilities to write data back into the underlying EHR than there are to read data now. So that's a current limitation. But for sure, the basics, Corey referred to the 80% rule. What we're starting to see is a rapid approaching of that ability to get at the core elements of data that you really really want to be able to extract about patients from an EHR and expose that data to for whatever purpose you need. Now that may be the transfer of data from one part of your organization to another part. It could be between one organization to another. It could be to a new application that you want to implement that needs to consume that data. All of those things are now starting to be seen come to the market. I think we're still at a very early stage where there's not a ton of these things on the market yet in terms of deliverables, but that is really going to change quickly because there's more and more, I have more and more awareness of various organizations, both commercial as well as provider organizations, that are really heavily investing into work with FHIR. You mentioned what are we doing with FHIR. Here at Boston Children's, two of my colleagues, Zach Kohani and Ken Mandel, several years ago wrote an interesting paper in which they hypothesized this idea of having essentially interchangeable, pluggable applications, if you will, into an underlying EHR framework. The analogy they used was an iPhone or an Android device. You can go to an app store. If you don't like the Maps application that came with your phone, you can go to an app store and get a new Maps application. And that app can be plugged into your underlying phone infrastructure. It can take advantage of the GPS technologies within and so on. Well, they hypothesized that healthcare IT should be the same way. And so that was the genesis of the SMART application standards. And initially, when we started to build out SMART applications, we had to cobble together the interfaces, the data interfaces to the underlying EHR. But now with the presence of FHIR and its ability to standardize those application interfaces, the data interfaces rather, we now have this ability to develop, quote, SMART on FHIR applications. And this is really exciting now, and it starts to make that theoretical idea of a few years ago start to become a reality. And so I think we're at the cusp of a big explosion in terms of the development of these kinds of applications.
Very good. Dr. Rob?
Would you please put the questions back up on the slide? Thank you.
So, you're welcome.
Here is the commitment from the federal government. If you look at ONC's website at hit.gov, the federal government is supporting FHIR and are asking for ideas to help the consumers use their health information. They're asking improve user experience. They're asking coordinate open information about EHR. So what that really means is that our biggest payer, Medicare, one day will also support it. So as Dr. Nigrin said, that the explosion is about to happen. And what's happening is this, that when you ask what can FHIR deliver today. So FHIR is a set of resources, and each resource can be used for different things, from demographics. So we at Hackensack are working for meaningful use too, all the 20 resources that's available. Presently, we have open FHIR interaction with 5 different EMRs. We have successfully done that. And we also recently completed the entire Meaningful Use 2 stack, and we are using them for read-only, but we also use a company that's on the line known as Infor that helps us to write it in the middle. So what FHIR can deliver today, it's a standard base, and we are trying to do it together. So the latest one is DSTU2, and DSTU3 will be coming out. We work with a small community of people in which all the major EHR vendors are there. And he mentioned Ken Mandel and Josh Mandel, and these are very important people, and they all get together. We go there. There are marathons at every place. We participate in it, and we openly share with each other the resources that we have used, and there are open FHIR server. It's not like some secret that you can't participate in it. Anybody can participate in it. It's all open. And so what is that doing is that it's allowing people to collaborate with each other and actually share discrete data. We have reached out to 3 other major EHR vendors, and when they will raise their FHIR server, we are ready to connect with them. The limitation that we are talking about with any new standard, it has to mature, but the explosion is not like years away. The explosion is months away. And as I mentioned that the federal government is behind it, the biggest payer will be behind it, and biggest insurance companies have also started moving from building FHIR capability from moving away from traditional HL7. I don't want to mention the names, but I know 2 of them. They are working on it so that the transaction becomes easier in real time. At our place, we are using it with 5 other vendors, and we are successfully receiving. Not only that, but we also receiving information from other people.
Corey, any comments on the questions in front?
Oh, yeah, absolutely. But first, I'd like to start with saying that the Cloverleaf platform supports web services and RESTful-based interfaces, including FHIR, and you can configure your system to support many of the resources and interactions today. And as Dr. Rob stated, we have a live implementation at Hackensack UMC. And we are continuing to build out resources that can be installed without the need for extra configuration. As far as these questions are concerned, I think I'd like to tackle the limitations and how they can be overcome. The first I would say is that FHIR is a standard. It is an abstraction layer that has its good points and its bad points. A good point is that we're all talking the same language. Bad point is it's not going to cover absolutely everything for everyone. There are compromises that have to be made with any approach to interoperability. Considering that, I wouldn't say this want to deal with specific limitations as much as I would say challenges that will need to be addressed. And as Dr. Rob stated, it's fairly new. There will be lessons learned, and it will need to mature. On the more technical side, because of the 80% rule, which keeps the standard simpler, it does come with the reality that it's not likely to meet all of your needs unless you just want a plain vanilla implementation. There will be a need for profiles and extensions that cover specific use cases, and that will need to be managed. Then there's orchestration. When we talk about the great triumphs of internet-based APIs like Twitter and Facebook, we're usually talking about a limited number of services or servers and for those great successes. For healthcare, we're looking at the possibility of not only every healthcare institution having their own server, but each of the systems that they implement having their own, right? So this is going to have to be managed. How do we deal with those things? First of all, while it's very new, there will be continued development to deal with the issues as they arise and as we get experience with it. As far as extensions and profiles, we actually already have some experience in addressing this issue today. We have actually some U.S. realm or U.S. country-specific extensions that are needed to address some of the meaningful use and common clinical data set requirements. And there is a profile extension registry, and those exist within that. As far as orchestration is concerned, there will be tools that will be built to help address this. Also, I think collaboration projects could assist. We have example models of this being done today in the document sharing networks with Care Equality, eHealth Exchange, and Commonwealth. They enable greater access across larger populations and some orchestration and process workflow.
Very good. I want to go back quickly to our poll and look at the results. So we're going to share the results with you. Dan, we see that 27% are doing something with FHIR and 71% are not. I believe both you and Shafiq referenced an explosion in FHIR activity. What do those numbers, again, unscientific, but maybe let's say there's something to them. What do they say to you?
Go ahead, Dan.
Go ahead, Shafiq. No, go ahead.
So what it tells us is the following. Remember, most bigger health systems and everybody else, they're waiting for their own EHRs to develop FHIR and FHIR capabilities. That's one. Second, people were waiting for MU3. Then people were waiting for the rule of API. So this waiting period has come to an end, which is coming to an end. Secondly is that as the DSTU1 became mature to DSTU2, developers came together. So, long and short, there are a lot of developer communities have come together who have done little applications. So that critical mass is getting there. Now, some people, the number what is saying is that 27% or 30% or one-third of the people who are doing that critical mass has accumulated. What I am visioning is that based on the support for the federal government and based on the biggest payer may announce all of a sudden, that will totally, and the two big health insurance company who are going into the world of FHIR, as the capabilities have matured and Smart on FHIR has matured and OAuth has matured, the explosion is very near. And also the part that makes it very good is that most people are sharing still openly.
Very good. Dan, your thoughts, any more thoughts on the poll results?
Yeah, I want to echo what Shafiq said. When you consider that this thing has not really been around that long, 27% of the folks already doing something with it, to me, is an incredibly fast rate of acceptance of this new technology. If you asked the same question 6 months ago or 12 months ago, you probably would have seen a number like 10 or 15%. And if you asked 18 months or 2 years ago, it probably would have been 3%. So when you consider our industry, which tends to be a little bit slow moving, and that was a little bit of a joke, that to me is like an exponentially fast rate of growth. And I think if you ask the same question in another 12 months, you're going to see it at 50 or 60%. So I don't see that as a low number at all. In fact, quite the opposite. I see it as a big number.
Very good. Very good. Corey, you want to touch on this one? Talk about some possible future use cases for FHIR?
Yeah, sure. So, where do we start? The world is open right here. I think let's start with patient engagement and empowerment. Imagine patients being able to manage their overall well-being, including health and fitness trackers, considering the current medical conditions. Right now we have a lot of health and fitness trackers. It's where people enter unknown information. Imagine that being married in with their current medical condition. There would be a lot more relevant advice as to the behaviors and health of the person involved. Another is clinical decision support. FHIR vastly opens the possibility of sharing knowledge artifacts and enabling clinical decision support as part of workflow, which is critical to making it useful for physicians. Research and clinical trials. I'm talking about more robust research populations where regular feedback of participants can be real time. You can monitor a person that's a participant involved in a clinical trial, and you can ask them questionnaires real time with their devices. FHIR enables that. Another item that was touched on a little bit earlier is administrative attachments. That is clinical information needed for claims and for things like prior authorization. And I heard a story not too long ago where a payer was actually calling up providers to schedule an appointment to go over there, go into the EHR with the credentials provided, print out the information needed for claims processing, scan it into a PDF, shred those documents, bring that PDF over into their payer space, and hand enter the data. Now, that's an extreme example, but it's illustrative of how things are today and how difficult it can be. And FHIR can enable payers, to query for documents that are related to specific claims and making it a lot easier. And ultimately, I think we're talking about real interoperability. it's not just the sort of data interchange that we're often seeing today. We're talking about actually enabling workflow integration, process orchestration, and coordination of all participants of care, including physicians, family members, and even devices.
All right, very good. Very good. We're going to do our second audience poll now, and you see it in front of you. Everyone should be able to join in on this one. Do you think FHIR has significant promise to foster interoperability in healthcare, or do you believe it has been overhyped? Significant promise or overhyped? Please enter your answer, and we will then go back to that and discuss it. Now, let's discuss that issue, and then we'll look back at the answers. Is FHIR the answer, or is it possible something else overtakes it to foster interoperability? Let me start with you, Shafiq, and I also have a different spin on this question. You, I'm sure Daniel as well, and Dr. John Halamka, some of the first to, I think of it as poker. I would say that a year ago, or 6 months ago at least, there's certain people that went all in on FHIR and started promoting it and working with it, and so there's something about it when you saw it. You said, this is it, this is something important, as opposed to looking at it and going, no, we're not going down that road. So if you want to just touch on that idea.
Okay, so the reason I went all in into it and my institution supported it was 2-3 things. First, the governance of it. It was open. That means everybody is invited. Second, the small group of people who met in a secret room somewhere and other people, they were all committed people. Third was that everything was there for everybody to look at and work with it. And once they worked with it, we were the first to share with people. So that open transparency and the ability to share, that was the first thing. Second, it's not as thick as HL7 is. This is lighter. It is HTML5 capable, web-based, JSON. So what that does is that it made it browser-based. That was the technical reason to support it. And the last thing was that all the big people who mattered, they all wanted to support it, including the ONC. That means the federal government. So when you have that kind of consensus and that kind, then only thing is left is to put sweat equity in it and go forward with it. And we all tried it. We tried the first one, didn't work out, second one, third one, and then we slowly and gradually, and today I'm telling you, we finished every resource that is needed for our EHR to do the entire meaningful use too. So requirements. So to do that with that passion, it was possible. So I'm telling you the good news is that it was possible because great minds got together for the greater good of the country. That's the reason.
Dan, I'd like your thoughts on the question.
Yeah, Shafiq hit upon a lot of the things that did it for me. Clearly, the open aspect of it, the lightweight nature, using modern technologies, HTML5, RESTful interface. When our folks looked at it and we started to do our early experiments with it, I mean, we literally were able to implement useful applications using some of these very basic resources that were very initially developed within weeks. I mean, when was the last time that we could implement anything in weeks as opposed to months or years? Right. And so that was something that really resonated with me. Shafiq mentioned the governmental support, but honestly, probably the number one thing that led and continues to lead me in thinking that this is the thing that's going to sort of do it in terms of being a standard, and it's not going to be eclipsed by other competing ones, is the fact that the vendor community is on board. You can't do any of this stuff if you don't have the underlying EHR systems, the integration systems, and so on, to have them be signed on completely. Because, you know, some organizations who have big IT shops and so on can do a lot of this development work, but many don't. And unless your underlying systems are going to be FHIR enabled without a lot of extra work on the client side, I think it's a non-starter. So because of the fact that very early on we saw a lot of vendor interest and support and active participation in FHIR, for me that was what really sealed the deal.
Very good. Corey, do you see something else overtaking FHIR, or something else coming up, or do you feel like this is sort of it?
Yeah, well, first let me preface my answer with the fact that I am a FHIR evangelist, but I'm also a pragmatist. So the question is it the answer? To that I say no. There is no eternal silver bullet that in healthcare interoperability problem. There won't be one thing that solves the world, right? We need to remember that FHIR is just one thread in a complex tapestry of health data interoperability, albeit a very promising and long thread. Ultimately, successful interoperability strategy will require the ability to weave together a wide-ranging set of data sources and formats into a cohesive solution. However, you know, again, I think FHIR will be very prominent and will open up many things that weren't possible just even in the recent past.
Very good. We're going to take a look back at the poll, and then we're going to take some audience questions. So let's share the poll results. And we see that 70% think that FHIR has significant promise, but 30% think it's overhyped. So Dan, I want you to talk to those 30%.
Yeah, well, you know, the proof will be in the pudding. You know, I can understand skepticism, right? We've had a lot of false starts in this industry and things that were hyped. So, you know, I can understand that. But I really do think that as the months tick by, you're going to start to see more and more real-world things being implemented using this technology. So
I do what Dan said, you know, is that for the first time, these are the United States of America. Nothing happens just because of government. Everything happens when the public wants it and when it's voluntary. So the vendor community is behind this. It just takes time to mature. So I'm not surprised by this poll that people are hopeful, because it is the people's work, you know, whether it's a vendor, whether it's a government, whether it's me, whether it's Dan, institution, it's for all. That's what's going to make it successful. That the FHIR project, the Smart and Proud project, done by HL7, is a work for all, and that's what makes it beautiful.
Wow, a lot of eloquence today. Corey referring to the complex tapestry of whatever it was. That was very nice, Corey. All right, let's take some audience questions. First question, can you discuss complexity of implementation and support? Basically, how much resources are needed to do the work and sustain it, and was it added as supplemental resources to other EHR/interface teams? Dan?
So a little bit of a tough question to answer, because my viewpoint of it is from being a very early adopter, in which our underlying EHR system was really, you know, still in the implementation state themselves. So we did have to invest resources together with our vendor to essentially FHIR enable the EHR. Where I think we're all headed is that as the respective EHR vendors and the interoperability vendors and so on start to build these things into their core products and therefore avoiding having the clients need to do that implementation themselves, you'll probably start to see a much diminished resource need in terms of implementation. And then you can really just focus on, okay, well, I've got my FHIR-enabled system. It exposes all of these FHIR resources. Now let me invest my resources into whatever application I need to tap into that data with. And so it's less of an infrastructural investment of resource and more of an application-specific investment of resource. And that obviously is going to vary. You can have a very simple application or use case, and you can have extremely complex, challenging ones. And so the resource demand of those is going to vary accordingly.
Shafiq, you want to touch on that? Or you want me to ask you? I can repeat the question if you want.
No, it's okay. I mean, people ask this question because there's a reason to understanding how to plan for resources and other things. So we joined FHIR, the journey in FHIR pretty early. And we don't have a robust team. We have a team of 5 people, including myself and 3 of my colleagues who work with me. And we also took some help from our typical EHR vendors and the typical interface engine company. That's it. And we put our heart and soul into it and went into it. Not making it simple, but you do need people who understand C++, or who understand programming, who understand JSON, who understand web HTML. So in every IT shop, you have 1 or 2 people who know that. And after that, to raise a FHIR server, you can do it in 2 days. I'm not joking. So, but to work on the resources and do that, the reason I'm telling you, Anthony, that it makes it so much easy that those resources are published today. For people who don't know that, go to FHIR.org. You will see it right there. All the documentation are there, all the resources are there, how to do things are there. So the rest is up to your ingenuity, how you want to participate in it, and how you want to progress it further. And if you get stuck with it, then you can talk to the community and raise a question, and somebody will answer you.
Very good, very good. All right, Corey, I'm going to hit you with a real technical one. Since RESTful APIs are supposed to be stateless, does the FHIR Working Group have a recommended standard for authentication/authorization?
Yeah, sure. So FHIR doesn't require any specific mechanisms for either authentication or authorization. The prevailing wind is towards OAuth 2, and there are other groups that are utilizing OAuth 2 in their sort of their requirements in their specifications for actual implementation guides. So I think OAuth 2 is right now the prevailing mechanism. As far as authorization is concerned, there is a little bit of a framework that is being developed for managing of consents. So there is one mechanism that could be utilized.
And Anthony, this is Dan. I'll just jump in. This is exactly what SMART does. This is the SMART part of SMART on FHIR, because that's one of the key components that SMART specifies is the authentication step. And as Corey mentioned, it uses OAuth and is all standard based.
Yeah, it's very important to understand that OAuth is an open standard for authorization. And it is commonly used for internet users too, like Google, Facebook, Microsoft, Twitter. They all use it without exposing their password. So it's pretty cool.
Very good. Let's go back to Corey again. Is FHIR fully balloted at this point? If not, when will this be a real supported standard?
Okay. Well, the short answer is yes, it is fully balloted. There is a process in HL7 for balloting. There is the current balloted version is called DSTU2, which is Draft Standard for Trial Use. Now, not to get confused, that doesn't mean it's not ready for use. It means that we're starting to use it, we're playing with it more, and it's time to start to jump in, right? The current ballot, which is open right now, is called STU3. They dropped off the D, and that will be a fairly, as far as the balloting is concerned, a fairly mature and solidified version. And then there's planned for next year in 2017 to create the normative version. Now, I would note that shouldn't necessarily wait until you have that normative version to get to use it. There are a number of standards that have been used while they were in a draft form, including the consolidated CDA. And my feeling is that with STU3, we'll have a pretty robust version. I also note that each the standard is being developed incrementally, and different parts of it will expand faster than others depending on the community interest, right? And so HL7 has developed a maturity model as well, that each resource has a maturity rating. So you will know which resources are more mature and more likely to be more static.
Very good. Shafiq, let's go with you on the next audience question. How well are EHR vendors adopting and making Smart on FHIR available to their customers? Is it available in 2016 versions? Is there a cost required by health systems to get that functionality enabled?
Okay, so that's why I mentioned Meaningful Use 3 and the API, and I mentioned all that. So there is a pressure on something known as Sync for Science. If you don't know that, Sync for Science is a call from the government NIH to hook up patient data, and patient can send this data anytime it wants. EHR vendors have gotten together, and they have all promised that they will participate in Sync for Science, some of them very big ones. So the answer to your question is that they are feverishly working. Commonwealth people, Cerner people, Epic people, Allscript people, you name any other vendor, they're all working towards it because it solves a lot of their interoperability questions. And so the newer versions that they are coming, which have to be MU3 compliant, they will have a FHIR component in it. And one way or the other, that will enable them to do their job much better for the point of care, for interoperability, for action-oriented thing, for consuming data from other different places, sending data. So that's what's happening in the industry.
Dan, any thoughts on that?
Sorry, I had put myself on mute for a second. To answer just very directly, I do think that most of the major vendors have something very close to sort of production ready, whether it's 2016 or not. Obviously, I don't know what each vendor's timeline is like, but I'd be very surprised if you don't start to hear from the major vendors that in their 2016 or probably latest 2017 releases, they will have a fully, supported FHIR implementation, at least with the basic resources like demographics, like labs, things like that covered, and it'll continue to mature over time. So it's definitely coming.
And Corey, where's Infor on this?
Well, as I said before, we're working on supporting the use of FHIR. As far, my history of my career has largely been in EHR systems, and I see a lot of them are picking up FHIR and have a significant interest in it. As I think Dr. Rob said, the challenge is going to be on sort of the writing of data, and there's a lot of challenges for the EHR vendors in dealing with that. They're not just trying to block necessarily, but you're going to have other systems writing into your data that may otherwise bypassing controls that you'd have in place. So our effort in Infor is to help address that, FHIR and other types of standards to make it work, right? So these systems support HL7 version 2 today, maybe for writing some stuff to the data. We'll enable a FHIR-based interface that can create HL7 v2 that can write to the EHR system.
Yeah, and for transparency, we are writing today using FHIR as a resource.
Very good. All right, final thoughts. Dan, final thoughts to your CIO colleagues, advice on what they can do, how they can take advantage of FHIR, what they should be doing right now, get their feet wet, go all in, and what does that mean? What are your suggestions?
Yeah, sure. So I think it varies depending on what kind of organization you've got. If you've got a smaller organization with not a lot of development expertise or resources in-house, maybe it's simply a conversation with your various vendors just to understand where they are all at, when they expect to have the functionality enabled, how they expect to start making it available, and what use cases it might help you with. If you have a moderate or large size organization that does have those development capabilities available, well then you can start to explore this stuff. As Shafiq said, it's all open source, all freely available, and explore it and start to think about what current challenges you've got at your organization and how some of these lightweight kinds of abilities that we now have to get to the data might allow you to solve those problems. And I'd urge you not to try and boil the ocean. Start small. You know, when we built our first smart application here at Boston Children's, it was for a very specific use case around measuring or evaluating blood pressures in children and the fact that they have different normal ranges depending on the size of the patient. That was something that our EHR at the time didn't do well. So we said, let's see if we can build a smart application, and now it's a Smart on FHIR application, that will solve that. So a very specific thing, but it allowed us to start to experiment and get experience, and in fact, it's a very useful thing. That application is still in active use today for us. So I guess that's what I'd say.
Corey, any final message for hospital CIOs?
Yeah, sure. As I said, again, there is no silver bullet. You'll need the right tool for the right job. FHIR really opens up a lot of opportunities and new use cases. Identify those as Dan said, look for specific use cases. Don't try to boil the ocean. But you also have to deal with other types of specifications all the time, right? And so you'll need to have a successful interoperability strategy, and you need to make sure that you consider that. And one last statement is that we had to go through a lot of material here really quick, and I'd like to extend an invitation to feel free to contact me about any questions or concerns or comments you may have regarding FHIR or any other interoperability standard that is out there.
Good. What's your email, Corey, for the folks?
Sure. It's corey.spears@infor.com. That's C-O-R-E-Y.
Very good. All right. Well, that's about all we had time for today. When you close out your window, you're going to be taken to a post-event survey. It might take you about 45 seconds to complete, and we would appreciate it if you spent the time. I want to thank our incredible panel, Dr. Shafiq Robb, Dr. Daniel Nigrin, and Corey Spears. Tremendous discussion. The depth of knowledge in this panel about this topic is probably hard to equal among any other three folks. I want to thank our sponsor, Infor Healthcare, very much for making the event possible. As I mentioned, you'll receive an email when our archive recording has been posted to our YouTube channel. For those of you who hold the CHIME CHCIO certification, attending our events gets you 1 CEU, so let CHIME know you were here, and if you've asked us to do so, we certainly will. Sponsorship opportunities to put together a panel such as today on a topic of your choice. You can contact Nancy Wilcox, and you can use our final slide as a certificate of attendance if you need it for another CEU program. Of course, go to our website to see our upcoming schedule. So once again, I want to thank Shafiq, Daniel, Corey, Infor, all our attendees. Everybody have a wonderful day. Thank you.